Let's start with understanding the prevalence of mental illness in our society. The National Alliance on Mental Health has reported some staggering statistics on mental illness in the United States. 1 in 5 adults experience mental illness each year. 1 in 25 of those a serious mental illness. In our youth population, 1 in 6 suffer, with suicide being the second leading cause of death in those aged 10 to 34. 47.6 million people, representing 19% of our population, are affected, and 7.7 million youth, representing 16.5. These numbers may surprise you, and they may not. There is a strong correlation in the comorbidity of mental illness and substance use. According to a recent national survey on drug use and health from SAMHSA, the Substance and Mental Health Services Administration, whose main purpose is the dedication to increasing public awareness and action around mental and/or substance use disorders, states that 47.6 million adults experienced mental illness in 2018, and 21.2 million people needed substance use treatment. Nearly 20% of adults experiencing mental illness also suffer from a substance use disorder. What is really alarming? 48.6% of people with a co-occurring mental illness and a substance use disorder receive no care at all. That is 1 in 2 people afflicted with no treatment. Another significant correlation is between incarcerated individuals and mental illness. In a study performed by the Bureau of Justice Statistics, they estimate 56% of state prisoners and 64% of jail inmates to have a mental health disorder, and up to 75% of juvenile offenders. The most common mental health disorders seen in incarcerated individuals are major depression, bipolar disorder, schizophrenia, and other psychoses. Our juvenile population suffers from substance use disorders, depression, and bipolar disorder. These are also staggering numbers to understand the prevalence of mental illness associated with crime. As you can see, mental illness is a considerable problem within jails, prisons, and juvenile detention facilities. A large amount of research argues that adult jails, prisons, and juvenile detention centers are the new asylums for mentally ill and are now the primary providers of services. But there is hope. The utilization of treatment services show great promise in reducing recidivism. Extensive research shows success when mental health services are utilized and suggest a 1/2 reduction in crime and incarceration after successful completion of a program. There are many programs in the treatment of mental illness, but I wanted to briefly go over some of the more common ones for context of this story. Mental health courts are rapidly becoming a necessity. There are over 300 mental health courts across the country and increasing every year. The aim of these courts is collaboration and specialized services that are catered to the specific need of the individual's illness. The goals being to support successful return to society after incarceration, to reduce recidivism, increase public safety, and improve the individual's quality of life. As we have seen in the previous slide, there is a clear relationship with crime and incarceration and the prevalence of mental illness. Understanding and supporting an individual's illnesses upon release has great success. Community mental health centers. There are over 2,500 CMHCs in the United States, providing community-based care as an alternative to a more expensive long-term institutionalization and long-term hospitalization. This allows individuals the ability to receive treatment, counseling, and other services while continuing to live a productive life, working in the community while living at home. Some others to note: psychiatric hospitals, which provide intensive in- and outpatient treatment in facilities that specialize in mental health services. Medication-assisted treatment offices and clinics can also be aligned with mental health services. Family support programs. These address the needs of both the parents and the adolescents that are either experiencing mental illness or at risk for illnesses. As I said, this is not an exhaustive list, but meant to give you an idea of what services and programs can exist in your community. Whether you are a CMHC or a psychiatric hospital, there are an entire range of programs and services that can be offered. But what we all have in common is the same program goals: to encourage health, quality of life, reduce the likelihood of relapse and recidivism. So there is great overlap in these arenas of treatment. Many of these clients will utilize different programs throughout their lives, but the obstacles for their treatment remain similar. Whether you're involved in a treatment court or an MAT clinic, we all have universal issues. We all face the same difficulties to successfully treat a client because we don't have reliable data to make choices in their treatment. It's an unreliable narrative because we are dependent upon the subjective nature of the client's description of the problem. There is a clear need to identify the nature of the client's symptoms. Are they due to the client's symptoms not being corrected with current medications? Are the medications not working? Or is the client not taking their prescribed medication and it is affecting their treatment goals? Or is the client taking additional substances that can affect their symptoms? Are they accidentally taking multiple medications that are combining their effects? Are they self-medicating with an illicit substance? The definitive answer to these factors can greatly affect the client's treatment plan, and it is imperative to be able to use objective data such as an accurate drug test for medication adherence. This is a problem that everyone agrees exists. We know drug testing for your MAT drug is critical for success in a program. We know testing for prescribed opiates is necessary in the management of pain. We check our T4 levels to see if our thyroid medication is working. Why aren't we using the same objective tools in the treatment of mental illness? Not only should we be concerned with adherence to taking medication, but we need to be thoughtful about what dangerous combinations could be occurring if there is more than one medication being prescribed. How often do we ever question a client what additional medications they could be taking? Are you taking additional antidepressants? Clinicians are often surprised by the number of clients taking more than what they themselves prescribed. How many other providers are they going to? Are they prescribing as well? Are they also making too many assumptions when prescribing? These are some real dangers here. Sometimes patients don't even know what they are taking or what they need to be disclosing. A client could be treated by one clinician for anxiety and another for depression. With the exception of a very few healthcare networks, our health system is limited in sharing of information to allow for collaboration. There could be a combination of drugs present, completely unknown to both the client and the provider. Can you trust that you're getting the real picture by your conversation alone? There is no way of knowing completely what is going on in this population if you aren't monitoring objectively through evidence-based testing. There is a clear discrepancy in what we think is going on and what actually is. Studies show that patients often overstate adherence because they fear disappointing their provider, and that clinicians generally overestimate their own ability to identify and quantify non-adherence among their patients, highlighting the importance of objective and validated approaches to measurement, such as drug testing. In our line of business, we know that medication and adherence to that medication plays a critical and necessary role for improved outcomes. The National Council published this Medication Matters paper in September 2018, which provides some significant information on medication adherence. The National Council is the largest organization of mental health and addiction treatment programs in the US. In 2015, they commissioned the Medical Director Institute to advise the National Council on best clinical practices and develop policy and initiatives that serve member behavioral health organizations. It states that non-adherence to medication represents a major problem that limits the effectiveness of treatment and adds to the burden of illness and cost of healthcare. Non-adherence affects outcomes through increased chance of relapse, hospitalization, use of emergency room, lifestyle disruption, and premature death. The added cost of non-adherence to the healthcare delivery system is estimated between $100 and $300 billion. Non-adherence affects patients, families, and communities through increased risk of suicide, homelessness, imprisonment, violence to others, and the trauma of violence. Based on the research performed and then documented in this paper, non-adherence to antipsychotic medications and antidepressant medications averages 42% and 34% respectively. However, we also know that non-adherence to psychotic medications can increase over time. The non-adherence phenomenon is illustrated with this picture on prescription data. The illustration shows that, as an example, out of 100 prescriptions written, only 50 to 70 even make it to the pharmacy. From there, only 48 to 66 are even picked up. 25 to 30 are taken properly, and finally only 15 to 20 are refilled. This quote seems to so eloquently summarize the issue. Medications only work in patients who take them. While our discussion today is focused on adherence to prescribed mental health medications, adherence to medication-assisted treatment medications is just as critical. Here are just a few recommendations provided by governing agencies and societies. The National Council for Behavioral Health recommends to utilize laboratory testing to monitor true adherence and to match provider intervention with medications to a patient's individual needs based on risk assessment. ASAM, the American Society of Addiction Medicine, states drug testing is an effective technology when the right testing is selected for the right person at the right time. The frequency and duration of that testing should be individualized and dependent upon the stage of their treatment. The panels chosen should be based on a patient's drug of choice, prescribed medications, and other drugs commonly used in the patient's geographical location and peer group. SAMHSA states the results of testing should guide patient care, and we should modify treatment plans to confirm our clinical impressions. The Medication Matters document states, it is critical all stakeholders understand that improving medication adherence is arguably the greatest opportunity to improve treatment outcomes and achieve cost savings in our healthcare system, and no single solution will be adequate. Let's take a pause to transition to the solution. I would like to poll the audience again. For those of you who are currently testing for mental health drug adherence, what source or matrix are you utilizing? Awesome, thank you for that input. This is quite surprising to me actually with this high level of urine. Let's take a look now at what's traditionally been offered for the actual mental health medications. Traditional mental health medications and what testing options exist now have been traditionally limited to blood. You're likely familiar with these medication classes listed here. There are many, many more medications available that are not listed here. This is just a brief example of these drug classes. You have your attention deficit disorder drugs, such as Adderall, containing amphetamine, and Ritalin, which does not contain amphetamine, but contains methylphenidate. Then we have our anti-anxiety medications, which is arguably the most common type of mental health disorder. These would be your benzodiazepines, such as Xanax, Valium, and Ativan. Some of these are short-acting and meant to treat acute panic scenarios, and others are long-acting for more chronic anxiety. Next are antipsychotics, Abilify, Seroquel, are antidepressants. These typically fall into one of two groups, selective serotonin reuptake inhibitors, or SSRIs, like Prozac, Zoloft, Cymbalta, and the tricyclic antidepressants, or TCAs. Finally, we have our mood stabilizers, which include lithium and the antiepileptics. Like I mentioned before, this is absolutely not a totally inclusive list. One of the largest limitations in testing for medication adherence for the mental health drugs has been that testing for the majority of these medications has been limited to blood testing. As you know, this requires specialized phlebotomy services and can be quite intrusive. Most treatment facilities just aren't set up to draw blood, but lab testing is an evolving thing, and we now have the ability to test for these medications in both urine and oral fluid. Urine has been really traditionally the standard in our industry, and many are comfortable with the interpretation of traditional drug testing. Here at Cordant, urine has the largest menu available and is preferred by many because it has a long window of detection. You have a large volume of sample allowing for additional testing if requested or retesting, and it's cost efficient. But it does have some limitations. It is the matrix most subject to adulteration and dilution effects. This is often combated by observed collections, but observed collections require designated facilities and can often be uncomfortable for both the collector and the participant. Additionally, urine has a preconceived negative connotation. Clients often associate it with illicit drug testing, and providers don't want to handle it in their practices. This is why oral fluid is rapidly becoming the preferred matrix for testing. It is an observed collection every time, so it does not require special facilities, is non-invasive, and gender neutral. This is a perfect matrix for population that an observed urine collection just isn't possible or even appropriate. For example, youth populations or transgender populations. It is almost impossible to adulterate and not affected by dilution or the participant's hydration state. We often tell our clients this matrix is a great protocol randomization tool. If you are suspicious of sample tampering or have individuals often that are dilute or even can't produce a urine sample, oral fluid is a great tool to switch up their testing to understand what is really going on. Cordant can test for over 62 mental health drugs in urine and over 55 in oral fluid. Now I would like to share with you some of our data and what we have seen that you are not seeing today. This data we are about to discuss is an analysis of almost 18,000 urine and oral fluid samples where a mental health medication was reported as prescribed. It is important to frame up this analysis in this context. The data we are about to share was not a controlled study, but a subset of data. So for example, it might surprise you that alcohol positivity was only 7%, but understand that not all clients ordered alcohol. If you only take away one number today, this is the one to take away. In almost 18,000 samples, 65% of samples were inconsistent or had unwanted, unexpected results. Of those samples, 38% tested negative for the drug they were prescribed. That is almost 40% of your participants that aren't adhering to their mental health medications. We know that adherence to prescribed medications is critical to successful treatment and improved outcomes. If you aren't currently testing for mental health medication adherence, this is what you are missing. Almost 20% positive for some illicit drug and 32% positive for some other medication that was not listed as prescribed. Let's look at these numbers broken down a little. 38% of all samples tested did not contain the medication that was prescribed as noted. These 5 represent the 5 drugs that are negative the most often in our samples. You see here nearly 47% of samples tested that had Abilify noted as a prescribed medication were negative. Sertraline then follows at almost 43%, clonazepam 42%, Seroquel 28%, and finally amphetamines at 25%. In the illicits column, 19% of samples reported positive for some illicit. THC was the leading drug, which probably won't surprise anyone here, followed by methamphetamine, cocaine, and heroin. Finally, are the unexpected medications not reported as prescribed and other substances, which occurred in 32% of samples: alcohol, amphetamine, hydrocodone, gabapentin, and nicotine. These numbers may or may not surprise you, but I wanted to remind you that this is a subset of our data and reflects what was actually ordered by our clients and tested within our labs. This is not meant to be a representation of a total population of mental illness. As I mentioned before, 65% was a number of mental health samples with unexpected results, whether they weren't taking their medication or taking an undisclosed one. Here's a closer look at the inconsistent rates by drug class. 65% was the average of all the drug classes within the mental health drugs. But what can we see if we pull each of these drug classes out? Samples listed with anti-anxiety medications take the lead here with a 75% inconsistent rate, followed by 67% for the antidepressant class, 66% for the anti-epileptic mood stabilizers, 63% for the antipsychotics, and finally the stimulants at 60%. This paints a quite alarming picture to what you are missing if you aren't testing for these drugs. Let's take a look at the specific subset of samples that were consistent with their prescribed medications. This data pulls out only the samples that reported a prescription and were indeed positive for the drugs in that prescription. For example, Abilify, and were indeed consistent and positive for Abilify. Even within this group, we see some surprising data. We have confirmed our clinical impressions. They are indeed taking their medication prescribed. However, there is still an overwhelming number of samples where something else was going on. In fact, almost 52% still had some unexpected result. 18% of these samples were positive for an illicit drug, and 28% of the total had some positive illicit or otherwise. So you can see here to the right, we listed the top unexpected positive drugs, including prescriptions and illicits: THC, alcohol, hydrocodone, amphetamine, and cocaine. 23% had some other drug also listed as prescribed that was negative. So they perhaps were only consistent with one of their prescribed drugs and 2 or 3 of the other they were not. What does this tell us? That even if the individual is taking one of their prescribed medications, 52% are still not meeting their program goals based on these drug testing results. This slide represents all of the most frequently prescribed medications in our mental health testing subset: amphetamine, quetiapine, sertraline, buprenorphine, which may or may not be utilized in your programs, gabapentin, aripiprazole, fluoxetine, citalopram, alprazolam, risperidone. As mentioned, this is not meant to be reflective of a total population of prescribing, but only what we see in our data. Here we see the breakdown for each of our most commonly listed as prescribed drugs for positivity. But what I really want to point out is the negativity rates in red. The red areas represent samples that were negative for what was expected to have a positive result. So citalopram, for example, of all the samples that noted citalopram, 25% of them were negative. 34% of prescribed alprazolam resulted negative. These last slides give us a very clear picture of what you may be missing if you aren't performing drug testing on these clients. We know medication monitoring allows us to quickly intercede in getting a participant on track. Adherence to their medication goals is critical to their treatment success. Now let's take a look at CORDANT'S program and the successes we have seen by providing mental health medication adherence monitoring to our clients. This subset of data includes initial testing when a participant entered CORDANT'S program. Each of these results included here were the very first samples provided by each patient that had up to this point never been tested for a mental health medication in urine or oral fluid. These numbers very much align with the averages we saw in the previous slides: 59% with potentially aberrant behavior on their very first test. As we discussed, this value constitutes our unexpected positives, unexpected negatives, and illicits combined. So we tracked these new participants and saw remarkable improvements over time. Of the original over 9,000 clients, almost 6,000 had an additional drug test. Of the originally inconsistent, 1 in 4 are now testing consistently with the reported medications. That is a 26% improvement in this piece of their treatment program goal. Being able to objectively and rapidly review drug testing results allows providers and case managers to quickly intervene for a crucial conversation, increasing a patient's accountability and improving outcomes. So our challenge is to you here today. Medication matters. Non-adherence is a major barrier to improved health outcomes for your participants. We know that relapse will occur and that the road to recovery is ongoing. The National Council tells us to continually monitor for adherence and to adjust your routines to address these expected variations to adherence that will occur. This adherence should be monitored by periodic laboratory testing. I will challenge you with this again. This data very much supports what we noted previously. Patients often overstate their adherence, and clinicians often overestimate their own ability to quantify that very adherence. Utilizing drug testing will provide you with the objective information that you need for successful outcomes. So what are you missing? These are our universal issues. If we don't have the reliable data to make choices in treatment, it's an unreliable narrative. You don't really know what is going on. What we have seen today is it is not only the adherence to prescribed medications we should be looking at, but what else is being seen in those samples. You need to know if your clients are taking their prescribed medications that will absolutely affect their treatment outcomes. You need to know if they're taking other medications or substances that could not only be interfering, but could be dangerous. The definitive answer to these factors can greatly affect the client's treatment plan, and it is imperative to be able to use objective data such as accurate drug tests for medication adherence.